And this first slide I really think is important because it shows that it was a major project within the VA system, and I get to speak on behalf of many, many people, only a few of whom are shown on this slide. But many of these people are involved in the organization and other aspects of this. So I've been involved in clinical trials with all the major companies, just participating in their clinical trials. Now, let's talk for a minute about the VA system. The first thing about the VA system is that it covers the entire United States, and it provides medical care to approximately 9 million people. All of these are adults who had served at one time in the military, who are now retired from the military. By and large, these people are lower socioeconomic status. They tend to be on the poor side. And because it's such a large area, it's divided into 18 different regions, and you see them in the different colors here. And I'm going to speak a bit about these. These are called VISNs, V-I-S-N, which we term a VISN. And each VISN has 6 to 8 medical centers, and so there's about 150 medical centers across this entire area, and about 1,000 clinics. So it's a very large system. And VA had recognized hepatitis C as a problem. And as I go through this presentation, there's a couple of things that stand out to me. One is that many of the things that we're going to talk about have been already implemented by many different people in this organization. And I want to try to touch on some of the things people said, but I'm afraid I'm going to forget quite a bit. But this first one is the John Ward comment, that hepatitis C in the United States, we look at it in the VA system as if it was taken care of in the last few years. But the reality is that the VA has been looking at hepatitis C as a problem for more than 20 years. And this just shows you that in 1998, the undersecretary for the entire VA said that all patients, all veterans must be assessed for risk factors. So it's been going on, the screening, for some time. And then in 2001, we had a clinical case registry. I don't want to cover all of these, but what we're going to do now here is I'm just going to highlight some of them, but I'm going to really move on because of time issues to talk about what is started in a couple of years ago when we really began to look at hepatitis C. And I'm going to then point out this is Washington, D.C., if I can get this. This is Central Office, Washington, that's responsible for all VA care. It then delegated HIV and hepatitis to this group, which then delegated Hep C to these people. I'm kind of in this group here. And what we did is that we asked every single medical center to create a team composed of physicians and nurses and pharmacists and other people involved in hepatitis C care. And then we provided the advice to those people on how to run things, so that these group members then looked at how they were organized at their hospital and tried to come up with ways to improve care. And then these people then at the individual facility level met together at the VISN level with 6 or 8 other hospitals in their region, and then we had monthly phone calls from here with every single team for the last few years, and where we talked about where are you, where should you be, what is your project. And we ask every single team here to write a project of process improvement, which I'm going to get to on the next slide, every single year. Tell us, and here's process improvement. We use lean methodology to say, tell us about a problem at your hospital, tell us where you want to be, come up with a proposed solution, implement it, and then measure the change and tell us whether it worked. And we didn't really hold their feet to the fire, but we made them write this process every single year, and then we reviewed it. So let me give you, and this I put in just for you, Jeff, because of the statement that you said, in Nordic countries, the specialists say, we don't have to take care out of our specialty clinic. What is shown in green here is the number of patients in my liver clinic at my hospital, both by platelet count, these are cirrhotic patients, but by FIB4. And I can tell you, I never have turned away a patient that's sent to me for a consult. And I was full of hepatitis C patients, and I would have put all the money in my pockets to tell you I can treat this disease. But what I found is that I was seeing about 350 patients, but I was not seeing 1,900 that were not sent to me. So the specialists think they're seeing everything, but they're not. And not until you use a population health approach do you really take care of this problem. So here's what we call a current state at my hospital in 2013. So what do we see here? A patient comes in, we screen them for risks for hepatitis C. If they're positive, the patient is notified and a consult is sent to me. I would then send them to a hepatitis C education class where they would be told about interferon and things like that. And if they were interested, they would end up coming to liver clinic, and then eventually, hopefully, they would get treated. But all along here, there were dropouts. And I'm just going to tell you one dropout. Between a positive patient, then gets referred to education clinic, 50% dropout, right there. So how do you get them faster from being tested to my clinic and get treated? Well, what we ask these people to every single facility, or every single visit, to come up with a system, a process improvement. And this is what we ask them to do. This is what's called an A3. We call it an A3. It's a 9-box A3 where we said to them, tell us what your problem is. Tell us what your current state is. Tell us what you want to do. Tell us what the problems are getting there. Tell us, if you get there, what you expect, and then do it. And then collect the data and tell us how it goes. And this is the confirmed state. You know, first 6 boxes we asked them to do when they submitted the proposal. These are after they did it. This is a very well laid out one. Not everybody did it this well, but every single visit was told to prepare one of these. And we then, on the conference calls, would say to them, where are you? And they would present their data on where they are in their projects. Data and metrics. My God, you can't get anywhere without data and without metrics. So what were we trying to do? We had what we call our lagging measure. In other words, where are you trying to go? You're trying to cure hepatitis C. What are the steps you need to do to get there? You have to screen them, you have to treat them, and you have to show that you have achieved SVR after treatment is cured. We set annual goals for this, and I'll show you some of them. And then, because it's a large system, we had data available for screening and for treatment starts and for SVR, and that data was updated monthly. We also created dashboards. A dashboard is a user-friendly database that you can I could sit at my hospital at my desk, and I could go into the patients at my hospital who had hepatitis C who had never been treated, patients who had, within the birth cohort, had never been screened. And that was available to every single facility, every single hospital, to any attending physician that wanted to do it. They could go in and see their patients and follow them. And they would get very detailed information, patient name, information, last visit, which primary care doctor they belonged to. So we set up clinical reminders in the electronic system if a patient came in. So from 2002 to 2013, we had risk-based screening. 2014 to now, we do birth cohort screening in people born 1945 to 1965, plus risk-based. We had reflex hep C RNA testing, and I think that actually was a major issue. So from 2009 to now, every single hospital, every single hep C antibody test that is drawn, if it is positive, the RNA is done automatically on that same tube of blood. Patients do not have to come back. There does not have to be an order. It's just done. And that is actually implemented. We've looked at it. It's implemented in more than 95% of the hospitals. There was one hospital where it wasn't really so well implemented, but essentially everybody does it. Performance measures for healthcare executives. They were judged on whether they were doing good screening rates. This is my patient who got a transplant, then got cured, and then went on to the transplant Olympic Games and won gold medal and silver medals and bronze medals. Now, you have to, now this again gets back to Jeff and what all these people are saying. How do you provide the treatment? And we changed some of the paradigms. We had group treatments. We've talked about, other people talked about telephone treatments with patients, video health, echo, and then you could send a consult from one hospital or clinic could send a consult to a high treating clinic. But to me, the most important issue were taking it away from specialists. Get it out there. Patients don't want to come see a specialist. Primary care physicians don't refer the patients. That's at my hospital, where I'm very well known. Patients don't come there. So we have to go to the patient. So we would go to the primary care physicians and we'd say, here's your list of Hep C positive patients. When they come in, could you please talk with them about treatment? At my hospital for the last 15 years, a pharmacist has done all the treatment. Seen the patients, ordered the medicines, ordered the blood tests, seen them in follow-up, and we have very high. And we can then take this to the primary care setting where each primary care physician has a pharmacist, and those pharmacists are treating non-cirrhotic patients. So get it away from people like me. We rewrote the treatment considerations so that any patient would qualify for treatment if they otherwise were adherent. Substance use was not an exclusion. Liver fibrosis was not a restriction. All hepatitis C drugs eventually made it onto formulary, and there was no pre-authorization. So that if a patient had Hep C RNA and they were in your clinic and they wanted to be treated, you should be able to prescribe it. So where are we? This is our screening levels, and this is where we were before we started kind of the intensive hepatitis innovation teams, and I can tell you that we were increasing our rate nationwide at about 1% per year for the 10 years before that. Then we institute these teams, and nationwide we go up 3%, we go up 4%, and then the people I work with on the first row of my slide, they're really nasty people. They say, let's go up 6%. And I say, you can't do that. It's impossible to start at a high level and make a system go up 6% in screening. But we do. We go up 6% in our HCV RNA screening rates in the birth cohort, and then we go up another 4%. So nationwide, across the entire VA system, we're at about 84% people screened. This is our viral uptake, Cumulative, from essentially the start of sofosbuvir. Harvoni started right about here, and you can see it's kind of leveling off, and I'll show you that in a minute. Here's our known HCV RNA positive, and we've started at roughly 168,000. It's a very interesting number because it changes every year, and so finding a fixed number and keeping it is a little bit tricky. But we've treated more than 80% of our Hep C positive patients. And Margaret, this is for you. This is where you are, Margaret. You are up here. And you are about to see a drop-off in your treatment rates. And this is what happens over time. You get all the people in there, and then all of a sudden, you get down to the hard-to-treat people. And this is what we're seeing. So if I put this back in, I wasn't going to do this, but this is a cascade of care. And what this is for the calendar year of 2014, 15, 16, 17. We haven't finished 18 yet, so the numbers will get higher. So that you can see our known Hep C patients has kind of been steady over that time, and most of them are linked to care. And the treatment has gone up and up and up, and the achieved SVR has gone up and up and up. And interestingly, what's over here is the presumed number of people with hepatitis C in the VA system has gone down. And the reason it's gone down is essentially for two reasons. It's not really because the number of people has gone down. It's gone down because we have now tested 85% of our people. And secondly, we know that the rate of positivity in these final people is low. Our initial rate was, where was it? Georgia was saying this. Your initial rate can be 10 or 15 or high percent. But as you get down and down and down, we're now getting a positive rate of less than 1%. So the assumptions that we made back here that it was very high was based on our assumptions of prevalence based on earlier data. So John, this is for you. what is it, this is my off the cuff, what is it that I thought was important in getting this done? This is not scientific, this is just like sit down and write it up, which is, you know, the world I love to live in. I can make up anything I want. Okay? As was stated so many times here, leadership support. We couldn't have done this if Congress didn't keep our feet to the fire and the head of the VA didn't do it. We put together teams at each facility, and these teams work together. They're multidisciplinary. There was great communication. There's SharePoint, monthly phone calls, system redesign. Look at what you're doing, find the problems, come up with solutions, and implement those. So that data. You're not going to get anywhere without data. Set your goals, figure out what they are, measure them, expand your ability to do treatment, and get it out of the specialties. So in summary, about 84% or more than 84% of the birth cohort have been screened. We estimate there are about 15,000 undiagnosed Hep C, and overall we've diagnosed more than 90% of the people in the birth cohort. More than 112,000 people have been tested, and less than 30,000 known viremics, and they are enriched in homelessness, substance use, other reasons, and they're going to be much harder. And to very quickly say, again, this process of setting up these hepatitis innovation teams to do system redesign, to work at the facility level and then work up, has been recognized by the people in the VA that know about it as a very good system. We are now using that for Hep B. We are now using that for the consequences of chronic Hep C, which is cirrhosis, to try to improve care. And they're taking this model and using it over in opioid problems within the VA. So this is, again, what Georgia and what John said. This is the leading edge of improving the kind of healthcare delivery for your entire system. And this, we had annual meetings for several years. We didn't have it this year. And this is a small number of people that were involved in the project. We just couldn't bring everybody to the annual meeting. But it is a big project, and it takes a whole lot of work.